My son's voice. Whenever he talks like he does sing, but not in a. I think he's got a very good
Howard, thanks for coming back to me on that issue.
Is that all right? Yeah.
Appreciated, yeah.
Good.
I think that was good.
Yeah. No, thank you. Yeah.
Peter, are you going to put the slides up? You know, when it's my bit, is someone going to put the slides up? Oh, okay.
Yeah.
All right, fine.
Yes, is that right?
Yeah, yeah. That's fine.
Yeah.
It's in Simon's board. I can look it up when I hold on. Hey Jen, how was your cyber road home?
Good, thank you. Yes, yes.
Good stuff.
I know, it's the last thing I needed. Dog shitting on my carpet this morning when I came down. It's the last thing
Well,
I
if
needed.
you can have a dog,
Two of them.
this is the risk.
There is a benefit of them over children.
Well, my
My
children
children are
don't
big.
shit on my carpet.
Mine have had their time. You're lucky.
Yeah, maybe I'm just fortunate there. Got the right children.
I remember my 6'6", 34-year-old when he was had a diarrhea. He was in nappies. And he grabbed my son.
Not when he was 34.
He yanked his nappy off and there was a
Yuck. Maybe this is just a theme. Maybe
no.
this is the
I
theme.
thought you meant now.
Hi, Howard. Hi, nice. I'm Jen.
No, not at the age of 34, Sarah.
I'm getting worried then, Margaret.
That's a worry, isn't it?
I
Yeah.
was thinking, what?
Margaret.
How are you doing? Are you going to need a sample?
I was also acting.
Yeah. That's the only one that's supposed to.
Good morning to those online. If you could indicate with a hand up or a thumbs up or a return voice, that would be lovely. Thank you.
Right, good morning everyone. I think we are ready to go. Sorry, Jack. What the feedback? Perfect. Right, I would like to welcome everyone to this meeting of the South East Coast Ambulance Service NHS Foundation Trust Board, and to welcome staff who are joining us both in person and online, and any public who may be observing us online. Do my confirmation as ever to say that it's a board meeting that's held in public and not a public meeting. And we'll talk about questions received etc. in a minute. But I want to do it's nice to be able to do introductions first. To be able to welcome both Jackie Lindrick as our new Chief Paramedic, most welcome. We'll say a few more words later. And Jen Allen, equally very, very welcome as Director of Ops. They both started on Tuesday, so they're all fully embedded. There should be nothing left to know now. You've got 2 days, but you're most welcome. And then Lara, who are let me tell you your name properly, Lara, who is Deputy Director of Ops and attending to support Jen, who are equally most welcome. Just to confirm as ever that we give the opportunity for the public to ask questions related to the agenda, taking questions at the end. We ask those questions in advance and just confirm that none have been received. You would have seen, apologies, Karen Norman, but Karen, honestly, that's above and beyond non-exec, not only being here on her holiday, but spending, I think, a lot of yesterday trying to circumvent various NHS IT protocols to ensure that you could join us. So you're most welcome, Karen. I'll then move on to declarations of interest. Colleagues will know obviously these are published, but I just do the pausing to be able to see if there's anything that any colleagues feel needs to be updated or anything in relation to any of the matters on the agenda today. Pause takes us to part 1 of the meeting. And we're going to just start with the minutes of the meeting from August. It's just to be able to check in terms of true and accurate record, and we'll move on to being able to approve them. But anyone spotted anything all good? Because I know there's some very eagle-eyed mistakes in particular. Nothing gets past. Nothing gets past. So that's great. If I could just set that there approved, we can log to be able to approve those. Fantastic. And then, Peter, we're going to turn over to the action log. I think that's quiet as well.
Yeah, that's okay. Yeah, Chairman. With 2 actions, both for future meetings. One will come back to this board in December, and the other is for the Quality Committee, and that will report in the usual way in quarter 4.
I should remember I do speak too loudly, so I thought, but I do need to switch the mic on. Apologies for doing that. Thank you. Then we have Audit and Risk Committee, and I'm going to turn over to you, Michael.
Chair, you put your report first.
Oh, my report. No, you have to stand down. Stand down. It's not here, to me. Too personal. Yes, and I'm very happy. The report, my report, I think, probably the points to highlight, I think, in terms of board assurance framework, we know that a lot of work has been done, and I'd also like to take the opportunity to thank Steve and colleagues for additional support to be able to help us to be able to, from our prior CQC ratings, to be able to work our way back into a stronger position with regard to governance, and I think we are well on the way. We're not saying we're not there yet. I think it's still a matter of a little bit of work in progress, and today's board meeting will be another step forward on that in terms of in terms of... go on again.
Sorry, Chair. Their mobile phones needs to microphone units. We've got Wi-Fi interference this morning. Don't normally suffer from it, but we are for some reason today.
Right. Switch mine onto airplane. Didn't want it on anyway, and thanks, Peter. That's easy to speak to. So yes, so we're going to. There's this basic principle of being a unitary board, and I think this is just worth just dwelling on just for a second to be able to say what that is and what that isn't, because we have our respective roles as executives and non-executives, and Simon leading the organisation, and then as non-executive, us being able to provide scrutiny and oversight. And I think what I hope is that we can still able to work in that unitary manner, which means that colleagues feel that they're able to, as equals, to be able to share challenges, share successes, share everything, but also recognise that we also have this need to be able to provide that critical friend input, that scrutiny input, and that's why we'll see today in terms of how we will take forward the agenda, that we will have committee chairs leading on each of our three pillars, and executive colleagues being able to add before we then take that out for discussion. More on that as we progress. I think also just to say, to note on the board development session that we had, we are very focused. We have a substantive item this morning on HR, and I think we all know that there's a real challenge there, and I think it was really helpful to have had that. We had a board development session where we had senior colleagues from across the organisation joining us, so we were able to really hear in real time what it's like, what the challenges are, and I think we all reflected, I have to say, I'm sure Simon will comment, but for non-executives, it was really quite sort of salutary to be able to hear about some of the challenges that I sort of described as sort of trying to jog in treacle around HR. And I think it was really helpful, that board development session, as have prior board development sessions been. Then finally, just on Council of Governors, I'm really enjoying sort of building that relationship. And we have with Andrew a new chair of governors who I have met with face to face to be able to talk about the role of governors and the role of the Council of Governors. And I think we're getting a really good, strong relationship, again, being able that they're getting that real understanding of their role within the governance system, which I'm seeing to be really, really meaningful in terms of holding us as non-executives to account for our performing our roles, but also about being the eyes and ears out there within our four health systems, being able to feed back as an additional loop, which I find particularly helpful. And then finally, and I'm sure some of you, you're going to be talking more about this, but it was my first annual general meeting, and it was. Wow, it was pretty special. I thought it was an excellent event. A huge thank you to everyone who put the work into putting it on, and I think it gave a real ability for us to be able to showcase our organisation, as well as actually to be able to show our governance in terms of our governors being there, as well as our non-executives being there. Again, I'm sure Simon will be saying more about that. So now, that is me in terms of my report. So now I can hand over to Michael. It's just, I was very excited to hear everything, Michael, in terms of audit. So.
Chair, that's really good. That's really good to know. I'm pleased when somebody's excited.
I'm worried.
Firstly, can I, we met a week ago, and as ever, my thanks to both executive and non-executive colleagues. I think we had a very good discussion. Just a brief update. I take my pen for dread, but you may recall that I said at the last board that what we got the financial accounts and annual report agreed and audited within the statutory timetable. The were some key lessons to be learned from the process. And we were pleased to take a paper presented by Simon, Director of Finance, and Judah, his deputy, about the lessons learned and how we are going to strengthen the resilience in finance and more widely going forward. And we will look at this in more depth when we agree the audit plan in the new calendar year. But I am grateful to the finance team for the really positive way in which they've learned the lessons. Again, a bit of a residue from last year's audit. Internal audit gave us the equivalent of a limited assurance around control environment. Again, there's a lot of action in place to remedy some of the issues that were raised, particularly in procurement and control more generally, and the audit committee will continue to monitor progress. We looked at the risk register as ever. I'm very happy to conclude that the risks on the register reflect the risks that the audit committee would expect to see. We emphasise the importance of making progress with HR support as a risk, and we note that is being included. We had quite a good discussion, I think, around further development in risk management within the trust, and we are challenged, I think, given the wide geographic spread that we cover, and we are moving very much to a more devolved, delegated system of management, and it's important that within that risks are understood and appropriately managed. And we've got the equivalent of ward to board in terms of the dialogue that we have about risk and how we manage and mitigate it. Really confident about the level of progress that is being made, and I would pay tribute to the work that Margaret, Director of Nursing, and also Ruby have invested in really the progress around risk. But for all organisations, risk management never stands still. You're constantly thinking about how you can improve and develop it. That was really, really important. And then finally, to finish on a really positive note, we have new firm of internal auditors, BDO. They presented their first report to the audit committee for this calendar, for this financial year, and this related to our freedom to speak up. Now, they were focusing very much on the process, the system that we had put in place. And I'm pleased to note that that got a good assessment from internal audit. Inevitably, there's more to be done, particularly around training and development. But overall, the process passes muster in many, many ways. And again, I'd like to thank Margaret and Kim Blackburn, our Freedom to Speak Up designated lead, for the work and dedication that they've applied to this. One thing I did miss, but I will mention because it reflects very much further discussion we're having on today's agenda, and this relates to the follow-up of previous internal audit recommendations. Again, good progress. There's still more to be done on those recommendations that relate to HR processes within the organisation. We took a decision to stop at this point in time because very much the recommendations, I think, focus on the symptoms of some of the deficiency we know that have existed in some of our HR systems in the past. And what we're more interested in getting is to the root cause. And again, later today on the agenda, we have the work plan for how we are addressing and improving our HR resource capability and support for our people. So we will return to those recommendations in December when we've agreed the strategy and the approach forward. And I think that's appropriate, giving Sarah and her HR colleagues a little bit more time to think through how the strategy is going to be implemented, and we are going to be talking about that later today. So overall, in conclusion, Chair, a long summary I know, but to give the board assurance from the audit committee, there is nothing that I would specifically want to bring to the board's attention today. Thank you.
Thanks, Michael, and it gives me the moment to be able to say thank you for the work that you do as chair of the committee and that the committee does. And I think we do, the way that you brought it out, and it's good to hear that your comfort with our new auditors with BDO, who I've certainly worked with a lot in the past, and just to recognise that it's one of those ones, isn't it, where the more eyes on it are going to be helpful, and I certainly feel that with both internal and external audit, particularly with internal audit. I think they can play such a helpful role as a critical friend in terms of being able to look at our systems and our processes. So, and I think that's very appropriate in terms of being able to support them to give us the right sort of the right push, but also know when to sort of pull back a little bit to be able to make sure that we're getting the pace right on this. So just open up if there's any questions or reflections for Michael. If not, as I say, these issues will be coming up. We return to them throughout the morning. Then we have a relatively short update to the Constitution, and Peter, you're going to run us through that paper.
Yeah, thank you, Chair. So hopefully the cover paper for this is self-explanatory. We're asking the board to approve 3 changes, all of which have been, updates to the Constitution require the approval of both the Council of Governors and the board. Council of Governors met recently and approved these changes, so subject to the board decision here, they'll be updated accordingly. 3 changes, just in summary, are: one is to the Constitution has, as originally drafted, included a maximum number of executive directors, so we're removing the maximum and including a minimum of 4, which keeps us in line with the NHS Act. Second change is around how we name our governor constituencies, following feedback from our governors. So we're reverting back to county-based names, which I think is sensible for everyone. And the last is just using the opportunity to amend our gender references. So, for example, there's throughout reference to chairman, which will change to chair. So if the board's happy to approve those changes, we'll update our published document accordingly.
Thanks, Peter. Yeah, again, I think this is all very much within the pretty sensible space. I'm not sure if there's any thoughts or reflections people have. No, I'm seeing a lot of nodding heads. So on that basis, I'm just going to say if colleagues are happy to approve those, I think that's really helpful to have. Great, thank you. Right, without further ado, we now move over. Simon, your report.
Thanks, Esmond. In the best traditions of continuing welcomes, I'm going to start my report by, again, welcoming Jen and Jackie, and rather than me speak on their behalf, ask them to introduce themselves. So I'm going to come to you first, Jen, and then Jackie, and just say a little bit about yourself and break the ice at speaking at the board by so doing. So, Jen, over to you for a bit.
Is it working now? Yeah. Superb. Okay, first test pass. Thank you so much, Simon and Esmond. It's great to be here. I'm Jen Allen. I've joined from a mental health trust, most recently Chief Operating Officer there, as people might be aware. Previously worked quite extensively across the NHS, acute and community services, but this is my first job in an ambulance trust, so I'm really excited to be here and to help you take forward your strategy around becoming a great place to work and delivering outstanding care for people and really being that system partner that we want to be across South East England and in partnership with others. So really excited to join the team and get my knees under the metaphorical desk.
Thank you. I'm also equally delighted to be here as CCAM's first Chief Paramedic Officer. I've worked in the ambulance setting or around the ambulance setting for about 24 years. So I started with London Ambulance Service as a trainee technician about 24 years ago, then became a paramedic. I've worked through a number of different clinical roles. I've worked in education and over the last few years more kind of in quality improvement, including spending some time with NHS Improvement as part of the Emergency Care Intensive Support Team. And I'm absolutely delighted to be here, as I've already said, and looking forward to sort of getting to work and working with all of you.
Thank you both. My report as it stands, I'm just going to draw out 3 things for reflection from me today. So the first is we meet on the turn of the year. So we're now officially in half 2, the NHS's fabled half 2, the difficult half of the year, because obviously that includes winter. But half 2 means that we should reflect back on half 1, and in half 1 we have ended it where we said we would be. That sounds like a small thing to say, but given the challenges that are facing the NHS, to be on operational plan delivery and to be on financial plan delivery, we'll pick up the detail of those in the various reports, is no small achievement given the various challenges that the NHS faces. So I just wanted to take a moment again, as I often do, to say thank you to all the teams, both in the front line, in corporate services, who have helped deliver that position. It is not easy at the moment. We recognise that round this board table, and our job is to hopefully use a bit of today to springboard into half 2 and support you in your endeavours. Just at the end of half 1, we launched our values, and I think those values of kindness, courage and integrity are going to be forming an important backdrop to all of our conversations going forward. I wanted to pay attention to here because often we end up talking about, substantive matters of business, whether we've done this or done that. But really the ongoing backdrop to our conversations now has to be, are we living those values? And I wanted, on my behalf, to give a very clear message to this board, but also to the wider organisation, that the values are here and we intend to promote them and live by them. And my key message, I think, is that all of us, no matter what our role, now have to live and work by those values. Because in listening to people, firstly, those values have found a strong resonance, so people are really attuned to them. But now they are expecting us to demonstrate that we are prepared to stick with them and live by them. And I wanted to make public my commitment to intend to do just that going forward. On matters of pragmatism, I think it's also important that I note and thank, as we head into half 2, commissioners in Kent and Sussex who, as part of our clinical strategy, have supported the go-live of our hubs. That's a really important part of our clinical strategy because it starts an intervention to try and defray demand from being automatically taken to hospitals. The Kent pilot that many of us have heard about throughout this year has been evaluated and found to be successful. Sussex have now put their hands up and said they are going at risk with funding the 2 hubs in the second half of the year. None of this is easy, you note the at-risk bit, from a financial point of view, but genuinely it's great to be able to report something here that from a commissioning point of view over winter will make a real difference to patients. We're finalising the model with Surrey at the moment. That's likely to be more based on a virtual model rather than clinicians in a multidisciplinary setting. But we will be moving into the winter with that first key milestone of the hubs up and running in some shape or form right across our patch. And I think that's a really important moment. And it shows the value of the work that was done, started last, can't remember now, David, but last September we began that journey, and the building and the collaborative nature of the conversation that we have now, a year later, got to the place where the hubs are happening across our patch. I'm also pleased to report that in setting up those hubs, we're very much focused on the quality impact of them, to make sure that patients are not in any way disadvantaged or harmed by that approach. That's really important. We've got to make sure that while we do different things, we do them in a way that carries both our staff, but most importantly, our patients with us. But mainly here to note my thanks to commissioners for their support of that. More to do, and for those who are eagle-eyed and have read the NHS England winter letter, you will note that already the ask around hubs has gone up another notch, with people wanting them running pretty much 24/7. We're not doing that yet, so that's the next part of our conversation. How do we get that? But it's great that all we're seeing from both national policy, national review, is reflective of the direction of travel that our strategy has taken us in. Unusually for me, I also have an item for approval, because normally my item's for update. So we're also reporting here on the outcome of the initial work that was done on our Southern Ambulance collaboration. Much work across the 5 trusts to agree a series of priorities which are presented to you here. They are in the areas of procurement, in the areas of digital and AI, and in the areas of productivity. How do we get a common metric? Now, the ambulance service is not, has not had a strong tradition of collaboration, so it's important, and indeed it's an expectation of our region and our commissioners that we start to engage in it. It's particularly important this year that we start to make some strides in addressing areas which, frankly, other parts of the NHS have progressed further on us. I note there, for example, things like procurement, but also in the areas of sharing good practice and good clinical practice in particular. That, for me, I think is an important part of the conversation going forward. And also taking a more owned view about the fact that at the moment all of us have very different operating models as ambulance trusts, which is again quite unusual, if I'm honest, and starting to get some standard conversations so we can compare in a helpful and meaningful way one ambulance trust to another. The aim of that surely is that we must all be, to Usman's words, be our own critical friends and not wait for somebody to do it for us. So a lot going on, and a lot still to do in the second half of the year. But those values for me will underpin all that we do, and we will be talking about them, promoting them, taking them out into the organisation fairly constantly from here on out. Thanks.
Thanks so much, Simon. I'm going to open it up. I mean, we've got the approval of the Southern Collaborative, the manifesto, but also any other general questions to Simon? Oh, so I've got Liz first, and then I've got Howard second, and then I'll be looking online.
Thanks, Chair. Simon, great news about the hubs. My question is, do we have adequate clinical resource to ramp up the hubs? Now, I know we've been working on them, but are we redeploying existing away from their normal duties into the hubs, which is a very exciting role to undertake?
So the part of the agreement, and I will bring David in a second to give a slightly more fulsome update than I will. The model of the hub is one of partnership, so our staff and clinical staff from other organisations. And the agreement that we've reached in Kent and Sussex will allow us to have that model working. In Surrey, we will be working with an on-call clinician who will be nominated on that day to work with us, so a slightly different approach. In terms of our staff, David, would you like just to give an update on the work that we're doing there, and maybe Laura as well?
Yeah, thank you, Laura.
I need a microphone. Am I still not on? Thank you for that question. So with regard to the hubs in Kent and Sussex, We are working through the existing rotas. We're not redeploying any staff. We made a conscious decision and commitment to our staff that in this financial year they would be as is. When we move to the next phase of the strategy from 2025, we will review it. So we're using the existing staff who've been working in hubs. There are paramedic practitioners and some of our Band 6 trained PACS clinicians. And we're currently reviewing all their rotas to ensure we have at least one available in the core hours of 8 till 6 p.m. in all of our hubs. And that work's all going on now. We have a board on Friday where all our clinical leads and partnership leads will be bringing the rotas for viewing and for some challenge around that. So we're using the existing staff doing what they're doing.
Thanks, Liz. I can see, so I've got Howard and then I can see Karen. Well, I'll do Howard and Karen and then I'm going to come up with Paul and Michael.
Thank you, Chair. Yeah, I just had a couple of points on the manifesto. One which I've spoken to Simon about just to highlight, I was a little bit concerned about the culture stealing with pride, and obviously it relates to ideas, and that's fine, but as it stands, the wording is a little bit odd for those uninitiated, as you can imagine. And the second point is one where it talks about best quality assets, which I had a slight concern with as well, for the reason that such a statement implies that we always go for the absolute top-notch assets. And I don't think that's right as a principle. What we should be doing is for each of our asset classes, whatever they are, we set a minimum standard that we should achieve, and then we procure, making sure we exceed that hurdle standard. But it's not always the very best assets, otherwise we risk gold plating everything. So yeah, it's a matter of the wording there needs to be amended to reflect that we should be setting our own asset standards, or with the collaboration, the minimum standards that we are willing to accept, and then we procure based on that, achieving that minimum standard, and get the best price, provided we achieve that minimum standard that we ourselves have set. Thank you.
And Howard, just to say, I find that challenge really helpful, and I will ensure it's reflected in the collaboration debates going forward. In our analysis to date, we've already found that there is variation in our practice that can't necessarily be explained rationally, and so in actual fact, our idea is levelling up to a minimum standard, which I think would be a far better form of words than the one that you have rightly commented on. So I will take that back into our debates.
Thanks, Howard. Let's turn to Karen then, online. Karen. Sounds a little bit echoey, but it's working.
So on the, thanks Karen, on the shared liabilities, the organisations remain sovereign. So the programmes of work are currently in development and will be presented to us at the end of a phase of work that's now going to take over the next couple of months. If we feel that the programme of work presented is not for us, we have the absolute right to opt out. So that protects our interests in agreeing to anything. I'm very hopeful that that won't be the case, but that just is a backstop, backguard for us. In terms of liabilities, what we've done is we've all contributed a sum of money to be a part of the club, that dependent on turnover, but that is the limit of our financial liability. So there are two controls there in place. In terms of stealing with pride, it refers back to this idea of we need to be far bolder, and indeed I would go so far to say it is now an expectation on us from our region and also from our commissioners that the ambulance sector starts sharing what it does well. All of us do some things well, none of us do everything well. And in the past, that's been a matter that has not been particularly well shared across the sector. And so we are now making it an absolute necessity that we do that. And I would say it's a necessity because I know nationally people are looking at what are we getting for our ambulance service commissioned pound, and if we don't do it for ourselves, others will eventually come and say, this is what we think. And I always think it's better to be ahead of that particular curve. So to give you one example, if you were to compare the 5 of us and take a typical job, we all send different amounts of resources to that job. So none of us, there is not a standard response to a 999 call. And that's, when you think about it, given the fact that we're not that far away from each other, apart from the east of England, which feels, you know, a bit differently located. We're not that far away from one another, and we all do something that is relatively similar, yet we answer the call, literally, in a very different way. And we need to get into that discussion and not be shy about it, in my view.
Very helpful questions. I'm going to continue on. So Paul and then Michael.
Yeah, so I had 2 questions. The first was around collaboration, because we've got a lofty ambition, then we got into 3 one-year deliveries. There's quite a lot in the middle in terms of long and medium-term strategies. So we wondered how we were going to keep the foot on the pedal and keep... It's great to see we've made a good start, but how do we actually take a sort of longer-term view and keep improving?
So we deliberately positioned this with 3 programs where we thought we could make immediate progress over the months ahead. So on procurement, surely if we are acting as one customer in 5 places, we should be able to get a better deal than acting as 5 customers in 5 places. And some of the stellar successes that the NHS has managed to achieve in this space are in that space, so we're trying to replicate that success. But you're right to say that this shouldn't be the end of our ambition. So in your own area, Paul, obviously there is considerable scope to align digital technologies across a group far more than we are doing at the moment. And indeed our aspiration, if the NHS Tech Fund comes out, would be to make a bid across all 5 of us and say, for one bid, you get 5 implementers. So we felt it was important to walk before we ran, in short, but our ambitions are far, hopefully, more significant than just this.
Yeah, thank you. Just making sure we keep it moving on, really. The second question was around the strategy. It's great to see we made a start. We're making feverish activity, implementing things all over the place, but I just wondered what the governance arrangements are and how we have a helicopter view down of how we're making progress. Do we have a programme office and that type of thing? Because it's...
So we are working, and we have recently established a PMO. We took that to the audit committee last week. Part of the tier 1 priorities for us this year is the collaboration space. So the way that I describe this is I envisage a joint swimming lane. And there are areas where we will have to get onto the joint swimming lane with other organisations. And that will involve, I expect fully that the PMO will be coordinating those activities. So that probably answers that question. I don't think there's going to be a central PMO, but the collaborative itself has a collaborative director that will be leading the work on behalf of the 5 organizations. So there's a little bit of central resource in the way that it's set up, but then there's an expectation. And quite a lot of the work we're doing with SCAS at the moment is a good example of that, where we have our 2 PMO teams working together on some of the joint projects that we're already starting to look at.
Yeah, I was just wondering how we get a helicopter view down. There's lots of information about progress, and it's great to see. But as a board, how do we get a helicopter view down of how we're actually performing?
If I'll pick up that. So in the collaboration, we have a programme office now established. There is a which has a managing director and support office that reports to me. I currently hold the rotating chair of the CEOs.
Well done.
It's not rotating very fast at the moment, but I am holding it. In terms of our internal programme office, which is what I think you might have been
Is it
referring-
about the trust strategy?
Yes.
'Cause we're really excited about it.
We have now got a programme office established, and we will use that to manage across the various swim lanes, because the complexity and amount of things we've got going on require us to hold that discipline, but to give assurance that is now up and running.
And it's not easy to do, is it?
But that is now up and running and in place.
Thank you.
Yeah, my final question. I should have said at the audit committee, as David said, we had a very useful presentation from the new leader of the transformation office, the programme office for the strategy, and we were assured about the progress that has been made, but we will return to that. My comment, Simon, and you're quite right to say that the NHS is scattered with examples of collaboration that have not delivered, and I suspect my only issue really is 2 words, I would say: pace and delivery. And I'm pleased to know that the programme director is working to you, but I actually would be looking for further assurance, and that assurance would come from having a realistic plan for delivery with appropriate milestones that we can see. And I understand the difficulties that people may opt out, but I certainly do not want CCAM to be, the casualty of this. I want to actually see delivery. I'm a bit nervous about AI because it's become the buzzword of the whole of the NHS, and it's going to solve all the problems. It's much more difficult than people realise. Procurement, I'm encouraged by, but in a commercial world, and Simon, you would know this, I would expect to see clear targets around the level of savings that could be achieved year on, and I just want a bit more rigour. So I'm very happy where we are at the moment, but in 3 months, 6 months, I think we need to see that rigour.
Completely agree with that, Michael. So we have a delivery partner now working with us. I am working with that delivery partner, so over the next month, the 3 work streams will be mobilised. Usman and I, or Usman also is part of a chairs group, so there is oversight of the work. My plan is that the aspirations, the delivery milestones, the delivery plan will be presented back to the chairs and chief executives who on your behalf will sign off whether those are acceptable. I would hope to have that no later than the end of November. And indeed, many of our colleagues have got significant aspirations and requirements that the seed funding that we've put in to support the collaboration makes a return on investment in this year on some of the items to do, particularly in the procurement space. Do I think that's a reasonable aspiration? Yes, absolutely, because frankly, we've never done it before, so there are bound to be some relatively low-hanging fruit that we can go after. And this board will also be kept updated on the progress and plans over the coming months. So I think by the time we turn around our next board, which I think will be in December, I would expect to be presenting an update on the plans and aspirations.
Thank you. That's very helpful.
Thanks, Michael, and thanks, colleagues. There seems to be a sort of a common message there, I think, which is certainly supportive of collaboration. However, as Howard says, however we frame it, of of our use of language. There's the support there, but I think we're also recognising, I wouldn't imagine CCAM has ever had so many sort of concentric circles to work with, because we're both panning up, not just with the Southern Collaborative, but also with increasing collaboration with SCAS. But we're also then focusing down, so we're not just talking about Surrey Heartlands as our commissioner, we're also, as Simon alluded to, having those sort of more localised commissioning discussions to make sure that the hubs are fit for purpose within their own localities. So for us as a board, we've got to stay agile to this, because we've got to be able to do the, being able to understand and set the strategy, being able to provide assurance in terms of delivery, and then manage risk around it. So we also have to be cute to it. So I think have that set out today. So that's all I'll say on it. Just to also say then, you've heard the caveats, Howard. I hope you're comfortable with that in terms of Simon taking on board. I do think it's really helpful, Simon having that first lead chief exec role. Also to say on the chairs group, which I'm not chair of, but what I have done is said to the chairs, their first sort of sector visit is going to be to our patch. So we're going to be doing some work, and I think it's just that we both Simon and I feel that we do want to not dominate, but we want to certainly be providing leadership where that's appropriate in this space. So that's just to confirm on that. So can I just also just have confirmation then that we are approving the manifesto? There we go. So listen, thank you very much. Excellent. So now we are on to our digital strategy. Stephen, you've been doing a lot of work, consultation involvement with us in development sessions and outside of them. So looking forward to your presentation.
Let's try this one. So thank you, colleagues. I'm bringing today the paper, Digital and Data Strategy, for approval by this board. I'm going to take the paper and the associated slides as been reviewed, but I wanted to kind of take us on a story about where and how we're going to get to the journey that we're on. So I built the strategy by taking on board the comments from the board development session, individual engagements with our clinical colleagues, to actually look at where we are today and where we need to be. I also went and spent some time on the road with some road crews to actually look at, did the technology work for them today? If not, what do we need to do differently? So that's built into this strategy. It's really been built, and it underpins completely the corporate strategy we signed off at the last public board. So this gives us the enablers to get us to where we need to be in the future. Front of centre of this is about our patients, giving our patients the right care they need by enabling our staff to have the right technology, access to records, going through the historic conversations we've had with our citizens and our patients to actually say, well, what works for them within the ambulance service and what doesn't. So in real terms, this strategy has been built up to get us ready and fit for the future. It will support our staff on their lifelong journey, but it will also make us that sustainable partner that we've always talked about. The first phase of the strategy is over the first 18 months. This first 18-month period is really getting us set and ready for the future. It gets us to the point where we need to be. Historically, within CCAM, we've not had the right processes involved, the right technology. Behind all of this, there's a delivery plan that really over the first 18 months of the execution underpins where we need to be. It gets us ready for AI. It gets us to the point where we can start to think about the technology we need to bring forward. Also taking on board where the NHS and where NHS England are taking us. Our strategy calls out what's the guidance that NHS England are giving and how will this support the Southern Ambulance Alliance to enable us to get to what I would consider the key headlines from the summary, which is fast and accurate access to patient care for our clinical colleagues, making sure that our patients can access records when they become available. When NHS app, as a good example, supports ambulatorial data, the patients will be able to see that. That's not there yet, but that's part of the long-term trajectory from the NHS England. Also to think about the automation and augmentation, how we can automate and improve the dispatch process. For me, that's really key to this, making sure our staff have the right tools, technology, making sure that experience is very well underpinned. So the basis of what we've tried to do from this strategy is to get us really fit to go. We know that we've got some long-term core technology that we need to rectify. We need to bring some different processes in. But for me, I would suggest that this strategy really gives us the ability to be ready to be the CCAM of the future, to be the leading digital mature ambulance service within the southern part of the UK. We will need to do some pivots in the team, but for me, the strategy will get us ready. It will remove our cyber threats. It will improve what our clinicians really demand around our electronic patient and care record. It doesn't drive their ability to be effective currently, and is within the strategy will determine over a period that we will be ready to go to market for the right technology to underpin us going forward. So in the fundamentals, this is the enabling strategy to give us the building blocks to transform the organisation over the next 18 months to get to phase 2, which is where we really accelerate the digital offer to our citizens and to our staff. I'm happy to take any questions or comments on the strategy as developed.
There we go. I've gone swap to this one. Thank you, Stephen. Very succinctly, clearly set out. Paul, I'm minded to come to you first to be able to see further thoughts and reflections before I open it up.
Yep, so I'm very supportive of the strategy. Steve and I have worked closely on this, and it's great to see a longer term plan that isn't just around technology, it's around how we can actually improve and support the strategy as a whole. So I've got a couple of questions. One is, how achievable is this? And it's an ambitious plan in 18 months. What are the main barriers to actually implementing it? And they're the first two, really, questions. So if you answer those, that'd be really helpful.
Thank you, Paul. And I would like to go on record, thank you for your support, your check and challenge all the way through the development of the strategy. I think you have been my critical friend. In terms of achievability, I set out a clear plan. That plan went through our FIC committee last week that sets out what we will achieve over the next 18 months. For me, it's ambitious. However, it is achievable in my opinion, having previously done this within East of England Ambulance, so I'm using tried and trusted methodologies. The outcomes that we will get from this are really getting us fit for the future. So I do see it's fully achievable to give us the technology stack in a secure manner as outlined within the document. In terms of the barriers are we need to go through the funding round, and clearly there is going to be a requirement for funding to do this in both capital and revenue. We will need to implement a number of new processes and resources, and I'm going to draw out that yesterday, again, we had some technology failures. Our processes, we need to tighten those up, and I've already commenced a review to actually understand the assurance that this board were given some months ago that we wouldn't have that again appear to play through. So I've already commenced a review on that. So in terms of the barriers, we will need to make some pivots to where we sit today. We're going to have to change the way that we deliver digital services, but we need to go to a process model that is known to the industry, which is ITIL. And at the moment, we are not following the guidance of which we all work within technology. Hopefully that gives you some assurance, Paul.
The technology.
Yeah, no, that's what we need, isn't it, actually? Yeah, I'm delighted that we're going to introduce more standard policies, and it'd be good to do a proper post-implementation review of what happened yesterday, because we've never actually made it all the way through one of those processes yet, actually. So that's really good news. The other question really is around, things change all the time, as we proved yesterday. How do you actually provide the flex and governance arrangements around this?
Through the papers I took through the governance board last week, I've identified and documented, which I've shared with the PMO, what I would consider to be the demand and fulfilment processes. So how do we align demand? So those processes have been developed. Papers to set those boards up are going through our corporate processes. So those artifacts are ready. Clearly things change, and we need to be agile in the way that we deliver services, making sure that we look at both clinical demand of change as well as technology obsolescence and change that can come forward. So I believe the processes that I've shared with our colleagues in the PMO really do align to what an agile organisation needs to be, but with the governance around scrutiny. And there's elements in there that I will be requiring support from independent experts to actually scrutinise what we're trying to do and how we're doing it. So I'm very cognizant that we do need a technology critical friend, which I did call out within the papers from last week.
No, this is great news. I'm very excited. Can't wait to get started. Actually, how often will you refresh the strategy? Things do change.
I see that I would be expecting to bring an update to this board on a 6-monthly basis. So over the next 18 months, I've split this into 3. Clearly, I'll work with my colleagues at both audit and at FIC, because there are some elements of the strategy cyber come through audit committee and others through FIC. So I'll be coming back with a 6-month rolling update to this strategy, again aligned to our clinical colleagues to make sure that we are giving and delivering the expectations we set. Where we do hit any checks and challenges, those are taken on board and brought back through both the governance framework and into our committees and back to board.
Brilliant. Can't wait to get started.
Very good to have that positive support, given your knowledge and expertise, and also thank you for again for that support. I mean, that is that is manifestation of that unitary board working effectively. Subu, you had.
Thank you, Chair. He stole all my thunder. This is really exciting. And well done, first of all, because I think CCAM has been after a digital strategy for a very long time. I think this takes us leaps and bounds forward. It's very exciting what's in it, and I know it's been very hard work having to deal with the business as usual where we are and trying to get to a very forward-looking piece. So well done on that, first of all, Stephen. It's really good. Can I challenge you a little bit? So yesterday we had a business continuity incident, and it felt like same old, same old. The same things that happened before that caused these BCIs. We had yet another one yesterday. So, you know, in your view, has anything improved? The second thing is this is an 18-month plan that you're bringing forward. And I would say that you've described it as a rectification strategy. So it's to get us to a place where we are then going to be able to do a 3-year to 5-year strategy. So when do you think we will be in a place where we can start to think very ambitiously, including the AI elements that you're talking about, to be able to then do that 3 to 5 year plan? Because there's some really good things in here that you cover around the NHS app and ambulance records and so on. These are all really good things. But when do you think we will be able to do that, given what happened yesterday, the rectification plan, and, you know, everyone else's ambitions on a collaboration?
On that. So in terms of the questions, yesterday, I think what that really proved to me, I was on the footplate within 3 minutes of the incident declaring into the EOC yesterday. It was fairly clear what transcribed. It was a failed technology change. I have to ask why we are doing technology changes in the middle of the morning, and that's something that I will take back on board, that we shouldn't be doing those in what I call core operating hours. So that's a first learning. In terms of what went wrong yesterday, the technology as part of the update left a vulnerability that should have, and we were all assured at this board had been resolved. So based on that, I've commenced work to look at our network in the round. That work, to be fair, I was with British Telecom at their corporate HQ. They are one of our providers of our technology stack. I was with their executives earlier in the week talking about a new target operating model, which we will clearly go to tender for, but to almost have a managed partner to work with us around our network. So from that perspective, I've already kicked off an immediate review with independent colleagues from outside of CCAM to actually look at what we found. Was it a bug, or was it what we'd left unfinished? And I can't give an assurance that it's not unfinished. I believe that we left ourselves in a state that wasn't good from the assurances we previously received. So I really do need to take that on board. In terms of the 18 months, clearly there is a lot of work to do. There is a high amount of what I consider to be remediation activity. However, this is not going to stop us enabling things. The things in the document I'm calling out around things like access to the National Care Record Set. We are one of the only ambulance services that don't have access to that tool. We've got shared care records within our region in splatters, but not complete. So my team are actually working with the national colleagues to bring a pilot of National Care Record Service access to our test group before the end of this calendar year. So that will give us one element. In terms of AI, we are ready to start AI piloting with where we sit today in and around the EOC. There is a document that I've been working with over the last few months with one of the industry partners and one of the global leaders in this space, which we'll be able to talk about at the Southern Ambulance Alliance meeting next week. So we will be able to do proof of value, proof of concept in AI before we get to the end state rectification. I would say it's quite normal now that you don't set 5-year digital strategies. Technology changes so quickly that the best practice given to us from the industry guidance is to break that down into 18-month to 2-year sprints. And I don't call it 2 years a sprint, but personally, rather than setting a 5-year strategy, which is what I've done in the past, things are moving so quickly that we need to evolve and change.
Sorry, that one again. So we've got 3. So we've got Howard, then I've got Karen online, then I've got Liz, and then Margaret. 4. Howard.
Thank you, Chair. Yep, just to reiterate, I think it's an excellent strategy, and very pleased to see how patient-focused it is. Whilst I'm happy to approve the strategy in principle, I'm mindful there are no costs associated with it, and that I'm not sure we're in a position to sign a blank cheque at this stage, but because there are no costings at all. And so, as I say, I'm happy to say in principle as a direction of travel and a strategy, but in terms of each and every step, we need to obviously go through due governance and process on that. My second point was really around, as people will have noticed, we've just had a preceding discussion on the area of collaboration with the other Southern ambulance providers. We have our own strategy, and we have our own now digital strategy. I'm sort of struggling in my mind how that will necessarily align with the collaboration, and how do we ensure that we get the right balance between delivering on our digital strategy for us and our strategy versus the collaboration. Thank you.
Thank you. In terms of the finances and the change within the paper, I've clearly stated that this will go into our budget setting processes through October. So I'm clear that elements of the strategy do need funding, but there's also elements of the strategy around getting us fit for the future and looking at our target operating model and our consultation that will be necessary so we can start to get the pre-work done aligned to the consulting that Sarah I know is going to talk about going forward post the end of the year. So there's a lot of pre-work that I can get on with and already have done to create to where we sit. In terms of what I call, the question you're bringing out is convergence. So how do we make sure that we get convergence between what's going on in other organisations and ourselves? I would say, I think I'm in a slightly fortuitous position. I'm national chair of all of the digital services within ambulance under AACE. Within the southern cluster, we got very similar, we've all got the same telephony platform. So we all use the same Avaya solution. We use a mixed suite in terms of electronic patient and care record and in CAD. If we were to walk back to where we were in a room, Simon and I were in a room around 12 months ago, we did talk about technology in and around the southern part of the UK. So there's already roadmaps to make sure that we can have convergence, that we are bringing together aligned technology solutions. So I think that actually brings us closer together, making us being almost front of centre to be part of a wider ecosystem. How to actually, I can give assurance that we've kind of considered this in how we've built our strategy. We're already in dialogue with SCAS around, for instance, the data components of this. So things are happening in the background, but I don't personally see it as a risk.
Thanks, Hannah. I thought there are two very helpful points in terms of understanding the direction of travel, connecting it to other people's direction of travel, and then knowing that we need to move in to start talking about financing at that appropriate juncture. But you very helpfully responded. Right, I'm going to bring in Karen, then Liz, then Margaret, but also to just make colleagues aware, we are just over an hour in to the meeting, and we're now, I don't say behind, because we've got lots of time still, but we need to be able to use it efficiently, and I do want to be able to give a good amount of time to Sarah. My sense is that we might, and also to welcome Nathan, who will be introducing the board story. We will do a pause. My sense is at about 11:30. I think we should all just be able to have just a 10-minute break, but just to be able to progress on, but just to be mindful that we've got quite a full agenda, and Peter has helpfully added half an hour onto our time, but that's half an hour more than half a day, so we will need to keep to time. Right, Karen, over to you.
I think you've covered a number of them in your previous responses, but I'm particularly interested in the issue of clinical engagement and culture.
Yeah, I'm cognizant of time, and I'll try and answer those questions as quickly as possible. I think history has told me that whenever you make a change within digital is just the enabler. This is a clinically led activity. So I would be expecting all of the work streams that are clinically enabled, clinically led, of which the technology is just one leg of the stool. So that's what history has told me from deploying an EPCR during COVID, which meant that things were different. Clinically, that program was, we in the tech part of the organisation just made it happen. Our clinicians did the real hard work. So for me, it's about all of the boards that I've established and recommended are all covering the wide plethora of colleagues, but very much the clinical voice comes through at all times. So I think that's the real kind of rub of the question. In terms of the deja vu, yes, I think we've all been here and seen technology projects fail. Make them small, make them achievable, break them down into components and see positive outcomes to create the snowball effect is where I say, and learn continuously. So do things in mini pieces.
Thanks for your question, Karen. To just add to that, I think, just going back to Howard's point, I think the focus on the patient is great to see, because then we've got a real sense of a sort of North Star and endpoint. Liz.
And I'm going to follow on from that. Thank you, Chair. Stephen, thank you. Fully supportive of this. And just wanted to say thank you for engaging and listening over the past few weeks, because I think it has made a real difference. My perspective is coming from the patient. When are we going to start engaging with them? Because this could be quite scary. And there's also a lot of negative press at the moment around GPs, virtual consultations, you know, moving to digital. So are we going to drip, drip, drip this to our patients, or are we going with a big bang? I can't really see from your time frame.
So we've taken on board the feedback that through the patient engagements groups historically. So we've taken a lot of their previous messages. The key one, which is, I don't want health inequalities here. I don't want to be digitally excluded. The strategy makes sure that there is no digital exclusion. So whatever and however we deliver care in the current system will not be excluded. So that was really critical for me. In terms of further and wider engagement, would like to have a further conversation with our patient groups and through our COGs, so that we can actually get to talk with the wider community to make sure that we don't miss any of those opportunities. But I think this is really about making sure that we are getting the right engagement from our citizens. It would be really insightful when NHS England, of course, give us the ability to post through the NHS app, because that's going to make a big difference as well.
Thanks again, Stephen. And just proving that we are a unitary board, Margaret. That's very nice that you're coming.
And finally, thank you, Chair. I just wanted to assure the board that as an exec team, we are fully behind this, and we've had some very interesting discussions. And it's been good to hear that Stephen has already, and you mentioned about going out on the truck with clinicians, already engaged with clinicians, but is very much minded to ensure that Ops and Clinical are very much involved in this, because there's those pathways we need to address the solutions for. And just to make a link to regulatory processes, I think it's great that from that board development session we had, where we all went with a big basket for our big wishes when you brought in the external partner, it's been narrowed down, but it's been narrowed down to already start addressing issues. So, for example, we know full well in the new CQC structure of single assessments that when they come into call centres, for example, not only will they be looking at our processes, our governance, but they'll be looking at the pastoral care. So recognising a lot of trauma comes to our clinicians, they'll be looking for our pastoral care around them. And here we have an AI tool being suggested, which in fact monitors the type of calls coming through, and after a certain number will say you need a break. But far more technological than that. But for me, for patient safety, for staff care, it's been really good to see that from that big discussion, we've distilled it down to some of the very important basics that are linked with operational and clinical problems and are there to help us solve those at the very beginning. So thank you, Stephen, and the team.
Did you want to?
Yeah, just to go around.
Simon, please.
There we are. I think, Jen, you had your hand up too. Did you want to add? Fine. So just by way of maybe drawing this item to a conclusion, I just want to make a couple of points. So the first is this is now a must-do for boards. It's identified in the Darzi report as one of the key shifts that will be prominent in the NHS plan. the next NHS plan published in March 2025, next 10-year plan. So we need to get good at this, and we need to get good at it fast. And the first step of that is the strategy. And I commend and just acknowledge the work that Stephen's done. Just 2 points from me. The first is, I think the point that Liz made is really apposite. How we communicate this to patients, and there is a real socialisation message. Esmond and I were talking about it recently. And I think as a board, when we come around our board development session in November, we need to look for ourselves at how are we communicating, not just this, because this is an enabling piece, but much more broadly, how are we communicating what we're doing across the various different swim lanes. There's one thing having a PMO, there's another thing, what's the public-facing message around all of that? So I think just to acknowledge that point and making it not scary is key. The other thing, which I think was a point of Howard made about how do we maintain coherence. One of the ways in which we maintain coherence, and I think you've heard it in the answers that you've had this morning, is as a board we have to invest in a CDIO sitting around the board table. One of the reasons why we have ended up with some of the problems that we've got is that the digital space has been a part of somebody else's portfolio. And that lack of focus, that lack of dedicated leadership has not served us well in the past, because it's been an add-on to something else rather than being, as has been evident here, the central part of the discussion. That's how we achieve convergence, that's how we manage the tension between collaboration and what we need to do on our own. That's how we manage keeping clinical engagement, but we have to invest in that capability around this table as a core delivery part of the strategy too, and it feels important to say that as well. But I would very much commend this strategy to the board. It will obviously go through our integrated business planning process, and so the reality of what we're able to achieve will be through the normal funding route. We can't comment on that yet because the NHS hasn't set its plans for the year ahead. But in terms of a vision, in terms of what we need to try and achieve, I think this is something we can and we should get behind. Thank you.
Very, very well put, Simon, and just allows me to just again say thank you for all your thoughts and reflections and comments. I think that, and also for your work on it, Simon, just grabbing hold of it as Simon says. You know, this is a must-do. I was at a health conference in Austria last week and was hearing about the Belgium health system where the electronic health record is available at the first point of contact. You know, that would be, you know, a wonder world for us, but it's happening. So we need to recognise that we're actually, when we just pull our heads up, which we don't, post-Brexit, we don't tend to do, actually there are a lot of folk who are already moving ahead with this, so we need to be able to catch up. So just to be able to take approval for that, to be able to see, thank you, Liz and Howard, for that, and thank you again for your work, Stephen. What I suggest now, Nathan, as you've kindly taken the time out, if you don't mind, Sarah, if we take the board story next and then a break after that, and then we'll all come very refreshed to hear everything you've got to tell us, Sarah. So, Richard, you're going to say a few introductory words. Over to you.
So welcome to Nathan to the board. It's really great to have you here. Nathan is our senior leader of the frequent caller team in CCAM, but is not only the leader in CCAM, also has a role as a national leader for frequent callers across the ambulance sector in England. So it's great to have him with us today. I'll hand over to Nathan.
Thank you, Richard, and thank you for the opportunity to come and speak to you today about our frequent caller team. Hopefully you can have access to the PowerPoint, the slide deck that's been produced. Is there a clicker? No, sorry, I'll do next slide for you. Thank you. So just a bit of background for our team. We're a relatively small team, so we're the second smallest in the UK, and there's 3 of us that cover the whole trust. You've got my lovely colleagues Hannah and Tammy, which cover the east and west of the trust respectively, and we cover all the counties. And we also regularly engage with our 15 acute hospitals, and we regularly touch base and collaborate with our 80 primary care networks and our 4 integrated care systems in the management of frequent callers to CCAM. So the next slide just talks about actually who are our frequent callers and maybe challenging some preconceived ideas. So we know that frequent callers are not vexatious or hoax callers. They're individuals who present with very complex mental health, social, medical care needs, and for whatever reason choose to route through 999 and 111 as first port of call instead of using a community-based provider. We know that in 999 our frequent callers predominantly are those aged over 70 and present with sort of long-term exacerbation of long-term conditions, including frailty and falls, where there's more of a desire for people to remain at home instead of moving to maybe perhaps more suitable accommodation. But we know that where commissioned packages of care, so 3 or 4 times a day, may be not enough to meet those needs, and we sort of manage those calls that way. And we know that for mental health, it may be that there's a lack of community-based support or an unwillingness for that patient to engage in that support. So we as a service receive those calls. And I think it's important to stress that our role as a team is not to stop someone calling completely. That's not within our gift. We're very reliant on system partners to resolve that unmet care need. But what we can do is intervene and identify those individuals and then work collaboratively at place and regional level to identify those cohorts and bring together some change. So in terms of our core principles as a team, it's mainly about identifying that if there is an unmet care need, then it's our job to work with system partners to meet that need. And once we're assured that that need has been met, our role is about challenging and changing and managing patients' behaviour and expectations. And moving forward, it's more about changing and managing system partner expectations of what we provide as a service. And we work very collaboratively with system partners across our footprint in identifying and managing frequent callers. So we work with the acutes, GPs, all emergency services and voluntary sector agencies. And in terms of how we support frequent callers, we follow a 4-stage process, which is a nationally adopted model where we engage with patients by way of telephone calls and letters. We work with the patient's lead GP or practitioners. And as we're only a small team, we have to be very selective about the patients that we manage. So we currently manage half the frequent callers that we can. So we've got about 250 that are open on our caseload. And it's about managing those patients which have a significant operational or EOC impact, or those that might be verbally abusive. And we complete home visits to see patients, which is a pre-arranged appointment which allows for a very demedicalised discussion to review a patient's care needs, holistic care needs, and again work with system partners to understand their expectations and how we can support them. In terms of interventions, the next slide, please, we use what's called response plans to safely reduce inappropriate ambulance attendances. And this provides the opportunity for enhanced telephone triage prior to ambulance deployment. These plans are tailored to individual patients, and the plans are reviewed and signed off accordingly internally. For very resource-intensive patients, or those that call multiple times a day, they may be placed on a time triage plan, and that restricts them to either 1 ambulance or 1 outbound clinical triage every 12, 24 hours or 7-day period. And these are reviewed at 6 months at a minimum by the team. As an organisation, we have to be comfortable in managing risk, because if we stop patients getting ambulances, we have to accept that one day there may be an incident that can occur. But our system is underpinned by rigorous risk assessment and collaboration with system partners and doing a lot of investigating work. And it's a very dynamic process that can be updated very regularly. And we know that positive risk-taking ensures that the trust resources are used appropriately to attend patients in the community, and it ensures that our patients take responsibility for their healthcare needs and that they contact the right provider at the right time. And we're continuing to work hard to change how system partners view CCAM, ensuring that we as a service only accept and respond to requests for assistance where there's a very clear clinical need. So 2 slides along just shows you some statistics for the last financial year. These are specific for 999 only. So we identified over 1,800 frequent callers that met the definition of 5 incidents in a month. You can see there the calls versus how many incidents were created. And out of those incidents, the breakdown of hear and treat, see and convey. And I'm really impressed actually with the hear and treat figure, considering the size of the team. And it just shows a testament of the hard work that the team have put in with the support of the wider medical directorate colleagues. And from the see and treat and see and convey figures, you can see the incident breakdown on the right of how that's broken down by category 1 to category 4 performance. And for September alone, we know that patients subject to any type of frequent caller plan called over 1,800 times, of which only 5% of those resulted in an ambulance response. The top table shows the top 5 frequent callers from the last financial year. The writing's a tad small, so apologies. But for example, patient 1 called over 1,200 times, or should I say incidents rather, but that only resulted in 1 ambulance attendance. And so we know that for the top 5 frequent callers, we've avoided over 5,000 ambulances attending, which equates to a sum of just over £500,000. Sadly, we have to use police and criminal justice system as a last resort. We do provide patients with a full opportunity to access the right care at the right time from the right provider. And this is only used when we're assured that patients shouldn't be calling at the frequency that they are. And you can see there the number of interventions. So 16 cases have resulted in a custodial sentence and 17 cases have resulted in a criminal behaviour order. And we know that by using time triage plans, restricting patients to how many contacts are allowed with us, so far this year we've managed to save over 4,700 outbound clinical calls being made from both 999 and 111. The next slide is just a few specific case examples. So patient A, in just short of a 2-year period, called over 6,000 times, which used over 370 hours of call handling time, which only ever resulted in 15 ambulance attendances because of their very robust frequent caller plan. We know that the cost to the trust for providing that activity equates to 70,000, but the savings avoided from not deploying the ambulances equates to over 200,000. And patient D shows that in the last 3 months we've had over 120 calls, but only 8% of those have actually originated from the patient themselves. And this just demonstrates a huge reliance that system partners have on CCAM in sort of picking up that activity or managing that risk, but reassuringly to see hardly any ambulances attended. So in terms of next steps, we'll be looking to commence 111 specific frequent caller management, commencing in 2025 with a 6-month pilot. And with the approval of EMB, we'll be looking to create a trust-wide withdrawal of service procedure to manage the trust's most physically and verbally abusive patients. We'll be analysing care line providers and targeting avoidable activity, because we know in 999 that 11% of frequent caller activity comes from our care line providers. We'll be introducing a new database to identify and manage frequent callers, and that will be aligned across 999 and 111, and that will be a joint venture with South Western Ambulance. And as we've discussed before, we'll be continuing to change the narrative of how system partners view CCAM in line with the trust strategy, and we'll be exploring potential funding opportunities to increase the size of the team in line with other ambulance trusts. Thank you for your time. If you have any questions.
Absolutely fascinating. And I think you could attend to everyone was, I don't know how many of you were absorbing so much information and such a clear overview of what the challenge is and what the solution is. I'm just going to open it up. Jen, did you want to come in?
If I just talk more loudly. Is this one working now? Okay, right, sorry about that. Thank you, Nathan, it was a great presentation. I'm Jen Allen, I'm the new Director of Operations, I've only just joined. In fact, you look kind of familiar, I feel like I've met you somewhere. Anyway, it was really, really interesting. I just wanted to make a point around shared records, which I would be really keen to think about connecting to the discussion that we've just had about digital strategy, because having come from a mental health background, I've done a little bit of work with frequent callers, and obviously that is one aspect of frequent callers that we'll be used to dealing with. And I think there's an opportunity potentially for us to have more collaborative management plans, because obviously we're not always perfect in other service areas about firstly, having robust plans for people who might require frequent support, and then sharing those plans and aligning them with the plans of other key partners like the ambulance service. So it's not to need an answer right now, but very keen to support you in thinking about that shared care planning aspect. And I'm sure it's probably part and parcel of your work, but how could that be made easier, optimised through digital as one of the possible routes?
Thank you. That's really a very fair comment. So we're fortunate to be able to have access to the Kenton Medway Care Record and the Surrey Care Record to access patient data. We're hoping with the introduction of the new database we've got, we'll be able to share the information we've got wider with operational colleagues and our colleagues in the control room to support their risk assessment process to be able to make the right call at the right time and reduce attendances.
Margaret.
Yeah, I think it's also important to acknowledge the small teams' efforts. CQC are very interested in this area, and we have a couple of names that we share regularly with CQC and have done. They've come in and scrutinised the plans. This team is regarded as holding really high-quality clinical safety plans around these patients, and I just need to note that down really and acknowledge the amount of work and effort that's put in to keep these patients as safe as possible. But as you see the statistics, these are tricky situations. So thank you, Nathan, and the team.
Fascinating. I've got Subu and then I've got Simon.
Thank you, Chair. Nathan, blimey. That's all I could tell, seeing some of those statistics, and nearly swallowed my own tongue. Good Lord, what a fantastic job you do for such a small team, and it's absolutely critical. So thank you for all that you're doing. You talked about, and we've known for a long time, that we carry a lot of the system risk. And I wonder how much support you're getting from our system partners around this. And Jen has just talked about sharing plans for some of these patients. But how much support are you getting from the system? Do they understand how much risk we are carrying? And are they helping and supporting with long-term plans so that we are focusing on our core service?
Thank you. They understand the level of risk that we're carrying. Unsurprisingly, they're not very supportive because it means that we're not going to be accepting those calls. And quite often, especially if you think out of hours, we're not accepting responsibility now at point of call, so they're passing it straight back to the police or the crisis line to manage that. And as that's a very new thing for them, it's very difficult to find a path moving forwards. But I feel supported by the organisation in making those having those difficult conversations, and hopefully we'll find a better solution moving forward, so to avoid patients either not receiving any help or looping around different systems trying to access the care that they need, which understandably isn't always an ambulance.
Over to you, Simon.
Thanks. Hi, Nathan. I've had the benefit of Nathan having described the service to me, and I mean it is a really impressive, clinically led service, and is exceptional when you compare it with other ambulance trusts. For the amount of resource we've put into it, the team are under incredible pressure, and we get a huge amount from it in terms of efficient use of our resources, which is again all about patient safety, being able to respond to those patients who absolutely need an asset, is in no small part down to Nathan and his team. So this is one of those win-wins for me. This is about enhancing clinical care, quality, capacity, and saving money. So I think this is really one where we do seriously need to take Nathan's advice and expand the team, put resource into it, and give the team the appropriate digital support and expansion across 111.
So Nathan, can I just say on behalf of us all, thank you. And would you also please pass on those thanks to the whole team, because I know it's a team effort. You were slightly too bashful, I think, in indicating... I did have a slight tech question, which I'll get out that you don't have to answer. Interesting, it's with South West, not with SCAS, was the thing that just kind of floated across my consciousness when you were talking about it, because technically SCAS is closer to us than Southwest. You can comment or not on that as you wish. If you had your wish list, and as you've done a presentation for us, you get to tell us what your wish list is. If you had your wish list, what would give us a flavour of the difference between us and other ambulance trusts in terms of investment? Just so I'm picking up on what Simon said, really. But thanks again.
Thank you. So with Southwest, because they've commissioned and purpose-built their own database using their own money, so we've got a really good insight there to purchase a license, basically, to use that software. So that's a clear win-win for us. In terms of how we compare to other services, so Yorkshire has a dedicated team of 10 practitioners. So they have 2 to cover 111, 2 to cover care homes and nursing homes, and the rest to cover the 999 frequent callers. And we know that obviously, as it's given the dedicated staff, you can optimise the use of hear and treat by reducing avoidable ambulances. So we know that we're currently sitting at 17% for hear and treat, but that's only because we're managing 50% of the frequent callers that we have. So in terms of a wish list, if there was a blank check, clearly, but I know that money is obviously very constrained and we have to make sure it's used appropriately, but perhaps exploring whether there's some more potential internal opportunities for staff to maybe be seconded to the team to cover certain areas of the trust and manage activity in that way. And thank you.
Excellent. Well, I'd just again add the thanks in terms of the presentation, and also the thanks in terms of the work you do. It also strikes me with the values that it's driven by kindness. Yes, there's the money side on it, but you can see where your drive is and your orientation is. So that's really lovely to hear as well. So thank you very much for taking time out to present. And then thank you all colleagues. I will say if we, it's 25 to, so 1:45, if we're back at 1:45, and then we'll be back with Sarah and the HR improvement strategy. Thanks. Let us all reconvene. Sustenance, fruit, fluid, exercise. Colleagues online, likewise. We're just waiting on Subo and Howard and Liz. Of non-execs, what can you do? What can you do? Yeah, I dear. Here we are. I don't know what a group of non-execs is. It a gaggle of non-execs, or is it? That'll do, will it? We don't want swarm, do we? I think gaggle's better than swarm. A Mensa. Yeah. If you say so. Super. Right. Just to make colleagues aware in terms of, that was a very helpful discussion, particularly on digital. We'll probably let's see, but around half an hour. Give half an hour aside on HR improvement plan, because I really want us to be able to consider it, and then basically I'll sort of divvy up the rest of the time by thirds to be able to allow allocations, because I do want us to finish on time. Peter's given us the extra half hour. I don't want to go beyond that. So to finish at 1:30, to help us to do that, I need to stay quiet. Simon, you want to lead off?
Of the most important items that we will discuss as a board from the point of view of strategic and operational need to get a grip on it. The HR improvement plan that's before you today is one that I am personally committed to, so is the whole exec team, and it's here so that it can get board support. It would be fair to say that this is not the first time that such a plan has been for the board. So we need to be confident in this discussion that the plan that we've got in front of us today encompasses all of the areas that it needs to, and also, crucially, to support Sarah, it is resourced in the way that it needs to be. So I invite comments and thoughts in those two places. Have we got everything down that we need to address? Have we put the right resource behind Sarah in order to help her deliver? And then the last point I'd make, we need to temper expectations with a degree of realism. There is a lot that needs to be done. Nobody would dispute that. But we also need to recognise that there is a finite amount of Sarah, and we're in a big moment of transition. So another key ask of you today is to help us alight on some immediate priorities that land us moving forward over the next 6 months in a better place, much to the points that we were making earlier about how do we measure progress. I'm really grateful to Sarah for the work that she's discussion. So without further ado, Sarah, I'll hand over to you.
Thank you, Simon, and thank you, Chair. So I'm really pleased, really, to be able to present this to everybody today, because I think it has been 6 months of hard work. We have looked at what the problems are, analysed what the problems are, and I think now we're at the right point in time to start setting out a plan for improvement for the HR services. And I really want to put on record as well the thanks to my own HR team, the line managers, the OUMs, the board, who've all contributed to the development of this plan, as well as colleagues from NHS England and the ICB, who've helped us to shape the plan into something that I think is realistic and achievable over a 2-year time frame. So I'll take the slides as read, if that's okay, and really just pull out the where we've got to in terms of identifying the 4 priorities for the next 6 months. So I think the slides sort of tell a story around the engagement that we've had since April around developing the plan. And I think when we went to the board session in September, it was very much a sort of integrated people plan with many sort of identified priorities. And I think the feedback from that session was really valuable and informative to get us to where we are today, which was, in order to achieve the plan, we need to set those clear milestones. We need to set 4 core priorities for the next 6 months. And then we have that emerging plan where we shape it over the next 2 years. So I hope the slides have given you some granular detail around the milestones in the plan and how we are setting ourselves up for success. In terms of the priorities, I would describe them as building blocks. So we're actually setting our foundations here in terms of how we write our HR service in a way that will deliver an HR operating model for the future that is good for our staff, good for our line managers, and can deliver our sort of overarching strategic objective, which is about getting things right for our Yeah, thanks. Right, thank you. So our HR function is a really important part of that because it is about part and parcel of the organisation and delivering that. So the priorities we've identified are, number 1 is about developing the HR operating model and looking at how our service is structured. So looking at how we review our structures to align ourselves to deliver the best possible people services function. Priority number 2 is about resolving our long-standing employment relations formal casework. It's also about building a culture towards resolution. So looking at moving away from the formalised ER culture that we've got at the moment towards a culture around resolution and mediation. Priority number 3 is about supporting our managers and our leaders in the best way that we can with some HR-focused employment relations training. So that will give them essential skills to be able to manage cases effectively, quickly, and hopefully to move towards that culture around resolution at the earliest point in time. I think the other thing to say here is that we also need to train our HR team, develop them as individuals to do the best job that they can do in our current culture. And I think giving them the tools to do that and the confidence will be really important in terms of how we achieve the outcomes we're seeking. Priority number 4 is about improving and redefining how we work in partnership with our trade union colleagues. This is a really important journey. We're looking at how we reshape the Joint Partnership Forum and the terms of reference for the Joint Partnership Forum to build a culture where we work and engage with them towards, again, that sort of culture around working in partnership, HR managers and the trade unions together to deliver, a safe and secure environment for our staff. Okay. So I think the next area, just to go on to, you'll see in the slide deck, we've outlined keeps going. Microphone keeps. Right, I think everyone's having microphone issues, aren't they, today? So the slides around priorities and milestones, I would take you to those just to say, do you agree as a board with the priorities that we've identified, and also putting in those key milestones so that there is that governance and assurance around what are we achieving by where, when, and how are we setting ourselves up for success. So I think those are quite important slides to review. In terms of the going forwards, how do we rebuild the HR directorate? I've had a lot of support from colleagues, from the executive team colleagues, and we've talked about how do we create capacity within our HR function to deliver some of these really challenging targets over the next 6 months. And helpfully, my colleagues have agreed to do what I would call an executive lean-in plan, which really gives additional capacity to our HR function from an executive support level. So it's not just looking at me. So I'll give an example. I've asked Margaret to, as Director of Nursing, to lean in to support the wellbeing function, which actually has got a number of clinical staff in there. And I think that will really help us to shape what that future service looks like. There's also our additional sort of leadership capacity and capability that we need to build in. So while we're going through the transition, I'm working with the team, working with Simon Bell as well, to put together a transition plan for resources to support this over the next 6 months, to make sure that we've got the right capacity to keep going our business as usual, as well as transforming our services. We've also commissioned some specialist external support, and that is particularly around the looking at some of the legacy ER complex cases, as well as some support around the investigations that we need to complete, either into disciplinary issues or grievance issues, to resolve those. So that will help in terms of our capacity to deliver over the next 6 months. The key areas of risks are around, I think, morale for our HR team, for our HR staff, because obviously any change is difficult. It's always challenging, so the additional sort of capacity and resources will help us to keep going and to support those staff through this transition process. I think the other area is around the culture of the organisation. So we need to be able to change things and deliver these changes. So I think working with my executive colleagues and others leaning in to really support and advocate this plan is so important in terms of its success. In the slide deck, there is an outline around the governance structure, which I think is really important, and it's been really helpful to work with Ellie, who's coming on the programme team, to help us to define this. So you've got 3 different levels. One is delivery, which is, you know, the work we're doing in the different around the different 4 priorities. Then you've got the escalation, which is the HR improvement plan steering group, and then the assurance level, which is the executive management board, but also the people committee and the trust board, so that there is oversight and making sure that we achieve the intended benefits and outcomes of the plan that we've put in place. So for today, I think it's really to take questions from the board to confirm, I hope, your support for this plan and the improvement plan as set out. I think, you know, the support I've got so far from colleagues has been really good, and yeah, really is open to questions around anything that you want to ask. And thank you very much.
Thanks so much, Sarah. Again, very, very clearly set out. And I think what you're asking is in terms of being, you know, there's a lot of detail within it, but there's also the overarching strategy and the timelines within it. I'm going to ask Subu first to respond, possibly as Chair of People Committee, and then I'll look around to see further questions, comments, looking online as well.
Thank you, Chair. And thank you, Sarah. And of course, at People Committee, we have road tested quite a lot of this already. And we understand, you know, a huge amount of work has gone into this plan, so we're really delighted to see it. We should let the board know that we went into quite a lot of detail, and fortuitously, all of the executive directors were at People Committee. So we were able to ask each of them how they will help and support deliver this plan. And so what is different, I think, about this plan is the amount of executive support that is coming through, and I think People Committee felt there was much more around shared ownership of this plan, and we hadn't heard that before. I think it felt very siloed previously, so I think People Committee got some assurance there that this is much more of a shared and owned plan across the whole of the executive team, which I think will make the difference. Thank you very much for listening to our comments and feedback as well, and you've taken that on board in terms of the governance of this and how we will know that there are reporting mechanisms. And I think we challenged a little bit on how will we know this plan is working. We don't want to wait until the staff survey results come out, because that will be in March. We need to have much earlier indicators to know how we are doing, and you've responded to that, and thank you for doing that. The one thing that I would say to board is that we should also be mindful that Sarah doesn't have at the moment a full complement of deputies, and we've talked about strength and depth, you know, sitting beneath executive directors before, but in this instance it's really important that you have a full complement of people that you can turn to who will help and support you to deliver some of this. So no doubt that will have some impact on some of the timescales, and we should just be mindful of that. So in terms of grilling Sarah, I think, on how we are doing, we should just take that into account in terms of how that will impact on the KPIs. And I know you're giving some thought to those KPIs and how we will measure and get assurance that we are progressing in the way that we want to. So thank you for so doing.
Thanks, Evan. Thank you for your words of support as well. I think that's very important. I'm going to go online first. I'm going to go with Mojgan and then Max.
Thank you. So I think in terms of access, the redesign of the HR operating model and the structures will enable us to build in that feedback to our new delivery. So I would see that the business partner function would be strengthened in terms of visibility, so on-site presence for responding to HR concerns and queries, but also that we have a model that works in a much more integrated way, I think, with the business, and that should deliver a more consistent and visible presence for the HR team. So I think when we're looking at what's our future delivery model, what are our new structures, that will be part of that decision making. So part of our principles will take that into account in terms of design. And the training point, I think, is really important, because that's around enabling our managers to feel confident in the decisions that they make. So that training, we are designing it at the moment, and we are hoping to roll it out over the next 3 months, basically. So I think that will be a real positive as well, to give managers the confidence and clarity and up-to-date information in that space. Thank you.
Again, you make a very important point, and I certainly picked up on the same thing, and I think you're very aware, Sarah, that people will be sort of testing the system early doors to be able to see have things changed, and can you reach out and get that support, and recognising what resources you've got to be able to do it. So thank you for raising that. I'm going to stay online now because we've got Max and then Karen.
thank you, Max, and thank you for your support. In terms of the lean-in, so describing that, I would say it's an informal mechanism to increase the executive capacity. So I gave the example of the Director of Nursing and Wellbeing. I think the other example I would give is Jackie, who's just joined us, is looking around the appraisal process, so looking at the quality of appraisals, stat and man training. So there are members of staff in my team who are tasked with that at the moment. But what it will enable, Max, is not a formal change to reporting lines. It's more about Jackie giving her input, knowledge and expertise to help my team to deliver in a different way. So it's more about the executives providing time, capacity to enable some of those services to optimise, the function that they're doing at the moment.
Helpful question, Max. Over to you, Karen.
Thank you, Karen. So I think I've referred already to the transition resource plan that we're putting into place. So that will enable a short term. So I've got, for example, somebody, a deputy coming in, an interim, I think 4th of November, to support some of that. We've also got an advert out at the moment for permanent recruitment to a deputy director role. But in order to supplement that, there is a plan in place to put in critical posts in the short term where we need that additional capacity. So that would be around employment relations at the moment, and building competence and confidence for the people who are in the team, working alongside those experienced sort of interims.
Yeah, no, please do, Karen.
Yeah, Karen, the way I'd see it working is that the consultants that we have helping us with our investigations and our casework will also develop the wider skills of the team. So, for example, in the way we may triage grievances or look at disciplinary investigations, our aim would be to utilise some of those skills to share them as part of that training programme that we're putting into place. So we very much want to build that sort of transferable skill set into our existing team. Thank you.
Excellent, thank you.
Over to you, Michael.
Thank you, Sarah. I really support this 100%. But my question is directed to you and Janine. And, I think we've been around quite a long time. You're a lot longer than I in this. But there have been a number of initiatives since I've been here to, restart HR. And unfortunately, for various reasons, they've not always, they haven't succeeded, to be honest with you. So I think we've got a steep hill to climb. And I just wonder, how are we managing people's expectations? Because as you quite rightly say, you can't do this overnight. This is going to take some time. But I suspect there's quite a degree of appetite out there in the front line for improvement very, very quickly. So if we don't manage expectations, we lose the support and confidence of the people that we need. I get a sense of it with your lean in and all of the other things. But can you and Janine just say to me, how do you think you're going to manage expectations?
Thanks, Michael. So, yes, it's a really good question, because I think part of this is about building and keeping that confidence from our line managers, our staff, and certainly I've been working closely with Janine to think about what additional capacity do we need for that continued communication around, what are we doing, what's different, and what can you expect to see in, 1 month, 2 months, 3 months. So I think part of my resource plan is actually building in a comms post, which will be really focused on that continual messaging and confidence around the plan and the implementation, which is so important and so key. I'll hand over to Janine. You might want to add.
Just to say, absolutely fully supportive of what Sarah said about my team dedicating some resource to support this. What I would say, Michael, is the organisation is understandably sceptical. I think it's fair to say, because as you say, we have been here before. But I think what we have seen is some shift and change in that perception, partly through the extensive engagement Sarah has done. I think the honesty with which she and her team have acknowledged the issues they have, which is different from before, if we're being honest, Michael. And I also think Sarah and the team are very cognizant of the need for change to be visible and feel real within a short window. So I think for me, absolutely recognising and acknowledging the scepticism, but I think this feels different in terms of its approach, and I think the honesty will help to convince colleagues that actually we are going to see some change this time.
I'm really... a moment. Yeah, I am assured by that. My only advice, if I can offer any advice, is I think we need some quick wins. And also, one of the things that I suspect concerns me, quite rightly, people committee audit have always gone on about, well, why haven't everybody had their staff appraisals? But actually, when you dig beneath it, it's not that simple as that. It's not that, it's much more complex, because what you get from the line is, well, the appraisal form is not what I think of an appraisal. It's about compliance with your training and all that sort of thing. I've almost got something around having an amnesty in that space of saying, we know this is difficult. This is what we would expect you to do, isn't it? I'm not saying I'm not the professional, but I do think there's something about showing a sense of goodwill with our people that we are moving this forward. It's around quick wins and showing a programme that, from their perspective, this is what they're going to get. Because I think your plan is brilliant. The only thing I was looking for was, if I was on the front line, when am I going to actually, at what point in time am I going to see something that is really tangible for me, that makes my life better and easier?
Just to say, Michael, absolutely. And we've had similar discussions at exec around the window for opportunity that we have with the organisation. I think another thing that feels different this time is this work isn't being done in isolation of a number of other key programmes of work. So Simon's been very clear with our senior leadership team around the values, and actually those absolutely driving what we do, whether that's HR or not, which will start to improve our culture. Under Margaret's leadership, the work around sexual safety, setting that really clear expectation, and our approach being very clear on that. The work we've been doing to move, which Sarah started already, to try and move the organisation away from the very formal approach to trying to resolve differences of opinion, which are going to happen. I think all those things taken together with this will add to the sense of things feeling different. I think there is a window for delivering some things that feel in the HR space that feel and look different, but I think there are a number of things coming together now that maybe we haven't had before, Michael, around those other key strands that will support this.
Okay, thank you.
Really, really helpful reflections. It's good luck. We're not actually on stage at the moment trying to earn money for this. But yes, they're working the moment again. Yes, so I think that was very helpful. I think just sort of bringing it back, I think, you know, what we're hearing is absolute support for the strategy. I think those questions are about, one side of it is the resourcing, and I think there's a central concern of not the lean in. I think fantastic to get the lean in, and I think, you know, additionally, sort of commend Simon for the sophistication of that sort of how you're supporting this as well as how you're leading it. But I think the recognition that you need that team beneath you, we know that you're making appointments, and that we need to be supportive and understanding that will take time, be able to bring people in from Storm Norm and get them, you know, fully performing. I think the other one is just about this, you know, hitting the ground running and being able to see deliverables. And I think that will be, yes, that will be for the board, but it's as Janine, as you were alluding to, it's very much for the organisation out there. They'll want some markers to be able to say, oh wow, not expecting that. But I just wrap it up with firstly to say, you know, if not now, then when? So I think the idea that this has to work now, not let's give it another go. No, it has to work now. Nothing else can work if this doesn't work. All the other digital strategies and hubs and everything else we can look at are being fundamentally held back by the fact that we don't have a functioning HR system. And then also to just say, I think it's, you know, you say talking the talk, and maybe the strategy is talking the talk, and we need to walk the walk. My sense is we need to keep talking even when we're walking. We're going to have to keep reinforcing this one until it hits home and people go, okay, we get it. And the very last one, just to say, personally, Sarah, I've now, on a number of issues, been working with you more closely recently, and I'm very taken. I think in terms of your skill set and your mindset, you know, you're calm, you're considered. You know, it's very much, this isn't personal, this is professional, this is a job to be done. I think you're very agile. You show good connection with the evidence, and I think you're and I'm also quite amazed that you're dealing with a lot of issues. What I really like is when I see you deal with the issues, I also see you leave process behind, and that's not always the thing you see. People say, oh, I'll deal with it, and then it's gone, but you're leaving process behind. So I think those are all good markers. So and we're all very, very, very much behind you for it. And I think on that basis, we're approving the improvement strategy, and we'll look forward to those updates. Right, we now have our 3 pillars, where we're used to our 3 pillars now. We just have a slightly different way in terms of how we're going to work with them, to be able to have our chairs introduce them, exec directors to be able to add comment. And that, I think what we're looking for is to not either hear everything that's happened within the committees. We know we don't need to hear that. Equally, we don't need to repeat what's happened in the committees, but we need to be able to both build on that. So for chairs to be able to tell us, well, actually, these are the issues coming out that really need airing at board level, and for us also to be able to do that additional dive in, to be able to provide that scrutiny, independent scrutiny that we as the board can provide. So sort of multifaceted, to be able to sort of improve that, the richness, the overall richness of the governance. And any board that I've been in, and any board that I've been chair of, I've always seen if the engine room of the committees is working, then the board is working. So I think that's the other part of it. And I think we've got the starting points and we're going to build on. So we're going to start with we deliver high quality care. And let's just also just add on timing wise, whether you want to bring in the winter plan within, I don't know whether you're minded to bring that in. If not, we can bring it in additionally. If you do want to wrap it in, then we can wrap it in. Very much your call.
Thank you, Chair. And obviously there's the summary of the Quality Patient Safety Committee. I'll just go through a few highlights from that. We've been focusing on right care, right person. Richard is our lead on this. And Surrey was our last county to go live, which was in September. So we're going to keep monitoring this with a further report in the new year over the winter period. We haven't seen any significant increase in calls to our teams, but we're starting to hear a little bit of noise around this now. So we will keep monitoring on this. In terms of quality account priority, we're focusing on unsafe discharge. This is our crews who are discharging at scene and not conveying our patients to hospital. There's been a pilot which has been undertaken at Tangmere, and if anyone was at the annual members meeting, the team were there, where they have followed up 100 patients post-discharge at scene, just to make sure that was the right clinical decision. It's been very positive. Our patients have actually quite liked a follow-up phone call from our paramedics just to check how they are. We have had to convey a couple of our patients to hospital, and it's been very much seen as a learning experience for our crews on the ground and part of our clinical supervision initiative. So we are looking at rolling that out further. But we were really, the committee, really supportive of this positive and proactive approach, not only safeguarding our patients, but our crews who are taking that clinical decision at the time. We're also looking up our patient care records, and I think the work that Stephen's done around our integrated care records, etc., will make a huge difference to this. But our project manager for this was very clear in terms of her timeframes where we'll get to on this as well. I think there is an alert in here, and it's around our volunteers and our CFR emergency responders. We know they're going to be pivotal to our clinical strategy going forward in terms of response. And I think there was a concern around how we were managing this group of individuals. We know we're actively recruiting throughout Kent, but we were unable to be assured of a clear plan once we onboard these volunteers. So what is their training? How do we deploy them? How do we retain them? And therefore we have asked for a follow-up review with that. And thank you, Jackie. We nominated you in your absence, but in the meantime, both Lara and Dan Cody and Richard's team agreed to look at that plan to make sure it was appropriate and effective, but felt that the joining of the 3 clinical directors working through this, because this is such a valuable resource for us as an organisation. And then also for advice, we had our annual reports, which was our controlled drugs report, our infection prevention and control, safeguarding, and learning from deaths. So, Chair, happy to take any questions on that, and also very happy for Margaret to talk about winter planning along with Lara.
Well, that's perfect, Liz, and thank you. Teed it up absolutely perfectly. What I'd be minded to do is to also see, Margaret, Richard, if you wanted to add anything to that, and then we can broaden the discussion. My sense is let's take winter as a part 2. Did you want to add something, Simon?
After our colleagues, obviously.
Thank you, Chair. So, no, thank you, Liz. Represented. Right, got it. Thank you, Liz, for representing QPSC well. I think the only other things I want to highlight, which come up from the IQR and the BAF in addition to that, is just a couple of things. One is just to make the board aware that we are now fully in PSURF. Our last SI went to the ICB and was signed off a couple of weeks ago, so we're the first trust to have that signed off in Surrey Heartlands. So we now only follow the PSURF. And then just to link how we have conversations across the subcommittees, you'll notice through the IQR that now we have the up-to-date reporting figures regarding violence and aggression. There was a peak in August, still within variance, which can now be related to the civil unrest. So from an average of 130 reports of violence and aggression a month, it went up to 160 plus. Interesting enough, though, in September, and that was mostly towards call handling, and also call handling staff who walk home in their uniforms, who are looked at as paramedics. So that's something we're picking up through a review of uniform wearing. But in September, we've already seen a drop to 90, which is below. So what we think is happening is there's a consciousness of thought out there at the moment that we should be more civil. We expect that to go back to average. Those are the only things I would state. Everything else is self-explanatory. Richard?
Thanks, Liz. Thanks, Margaret. The only two things to add from a quality perspective and patient care perspective is that we're making good progress on the redevelopment of the Medicines Distribution Centre at Paddock Wood. Building work is actually ahead of schedule, still on track to open at the end of November. And thanks to our colleagues who are having to work in a noisy environment while the diggers are knocking down walls and things like that to deliver our medicine pouches out to the ambulances on time, and we've had no issues with service delivery, which is a fantastic result for the team. And the second thing is that we've just started a clinical reference group with our colleagues at the region, NHS England and South Central Ambulance Service to look at our models of care. So we're doing this in a collaborative approach across the region, which is really exciting and should give us some leverage to introduce our models of care at a grander scale and with the input of experts from across the region rather than just doing it on our own. So that's really good progress. Thank you.
Simon,
just to comment on two matters you raised, Liz. So the first, in terms of right care, right person, I was on a visit to Sheppey recently, which was a wholeheartedly positive experience, but in the staff focus group, the sole and only thing that staff wished to raise with me was their experience of right care, right person. And so I commend continued focus on this. Specifically, in the right care, right person place, the concern was that police colleagues in operational real life situations were still refusing to commit in situations where staff felt they should. And more generally, in mental health space, the experience of overnight shifts in particular, where the sole and only jobs were mental health ones, one after the other after the next. And I think the clinical group now need to sort of start thinking about that. And that speaks more to what is available in the mental health space out of hours, was the concern that was being flagged to me. So I think it would be really helpful if the committee continued its focus in that area and thought on it. On the point about volunteers, just to say I agree. I have been talking with some of the senior volunteer leadership and more directly with some of our CFRs. And I've decided to commission an external review of the volunteer service, because I think at this moment in time it's important to take a stock take of where we are. We've done it with a number of other parts of our service to say, are we fit to deliver the strategy? Because you're completely correct, the volunteers in the broadest sense of the word play an incredibly important part in our life and will need to do so. And I say volunteers in the generic sense because one of the areas in my initial interactions with the group, I've asked Helen Vine, who's the National Volunteering Lead at ACE, to undertake this review. She pointed out, because we often focus on CFRs, that an area of outstanding practice within CCAM was our chaplaincy service, lest we forget. and the work that they do. So volunteers, I think, needs to be thought about not only in the CFR sense, but in the broader sense of people who make a commitment in their own spare time to us. But I wanted to acknowledge the point and say it's in our scope of review, and I'll be asking the senior clinicians to help me with that in due course. So thank you.
Looking around the room to see if there, and also looking online. Oh, I can see Mojgan, over to you.
Yeah, thank you. So at the moment, Datix Cloud DCIQ is working perfectly well. We haven't had any issues. Stephen and I are working very closely, though, because on two counts. One is the actual system has been sat with quality and nursing. None of us have got in our job descriptions technical expertise in IT systems. So we're going to be moving the hold and the hosting of the system over to Stephen and his team, and we're just working our way through that one. And on the other side, we're also, Stephen is going to be supporting us in going out for soft market testing. There's a lot of feedback around DCIQ from many, many trusts. There's also a lot of feedback from the other systems, I think it's fair to say. So what we're going to do is, in lieu of coming up to a chance to break our contract, is review to see what's out there and what fits best for us, particularly in light of where we're going strategically, both in the digital space and our overall strategy. Did you want to add any more to that, Stephen?
Yeah, clearly Margaret and I are working very, very closely on this one, and want to make sure that we've got the right products and the right solutions to enable us to run our business effectively. And if that means parts of the Datex platform remain and other parts we transition to an alternative technology set, we want to look at that in a completely open frame of mind. So we're clear that it currently is working, but does it really support our long-term plan as an organisation? So we're working effectively hand in hand to make sure that we come up with the right answers.
Earlier in the year around Datex, we did receive assurance at QPSC that there were no patient safety incidents and our backup and business continuity plans had been very effective. But yes, the review of the reporting system for incident recording is now underway.
Very, very clear in terms of getting that oversight. I have to say, just maybe one further question back to you, Liz. Just, we know that we've got the, the hubs, the new service strategy. I was really taken when you were saying that, looking back at those 100 cases and being able to say, were they all appropriate? Is that a general within your committee? Are you looking as a whole to be able to look not just at the quality part, but also where risk pockets might be popping up and whether they're being dealt with?
Yes, we are. Keeps going. Lara was at our last committee meeting, so we can triangulate both from a clinical and an operational perspective.
Thanks for that. Now, I'll just say as a general point now, because we have this reporting, we have this scrutiny, we've also got the ability to draw issues back up to the board as and where you may, if you feel that they're cross-cutting themes, and also just the point you were alluding to, Simon, we can then draw these back up into single papers that we can consider alongside the deep dive and all the work. So I was going through all the data that we've been able to marry between the two. Excellent. Thank you so much. And again, thank you for the ongoing work within the committee. Turning back to people now.
Do you want to allow Margaret to say anything on winter plan?
Oh, yes, sorry, yes. Thank you, Simon. Let's take that time on winter plan. It's a shorter paper.
It's a short paper, and I've
But-
asked Lara is overseeing this. It's been
Perfect.
recently handed over to Lara.
And then, thank you. You'll see in the pack that we've done just a cover sheet and an exec summary of where we are with the plan, and we wanted to bring that to board to show you what the priority areas are of the plan and the intentions of the plan. So the winter plan is being worked on now with representation from all directorates. It's been out for consultation, it's being developed, it's never going to end because it's going to be very interactive, very intuitive, or we keep looking at it and reviewing it. It had its first formal outing at SMG yesterday for an hour, where we really just focused the whole agenda on what do we want from winter plan, how do we get through winter safely with the backdrop of an increasing activity that we're managing, and also managing within the money that we have. So I think it's really tough this year. We know winter will be, but we need to, do our best to keep our performance going and to keep a safe service to our patients with the backdrop of an increasing activity and maintaining our performance metrics, particularly the C2 mean and hear and treat. So we've identified some key areas within the plan and things that will support us getting through the winter. They are, as we've discussed, the unscheduled care navigation hubs that the new 5 are going live for in October and into November, with one from Sussex. We're also developing and starting within the coming weeks a trust operations cell, where we'll be bringing together many of the on-call functions that are working well but are across the trust. We'll be bringing them all together into the EOC. We're piloting that in the east and the west, and we've got quite a strict evaluation criteria. We obviously, our focus always is on the wellbeing and welfare of our staff. Reported by Liz. I was wondering if the actual final plan should maybe go back to PPSC in November for assurance. But again, happy to be advised by colleagues, and if anyone does any more questions or challenges, maybe outside here, we can go through the plan with you in a lot more detail.
Thanks, Lara. Well, you were nodding on that one. So Liz was affirming that one in terms of the route back. Question, actually, just Lara, just contextually, I was just reading. I know it's slightly tangential, but just seeing flu jabs down, flu risk maybe a little bit up. Is that? Well, you might do it, might not. Yes.
There is a societal concern, so across population, that there's a concern that the uptake of flu vaccines nationally was quite low last year and didn't reach herd immunity. And we know from our experiences with measles, etc., that without having less of flu, so then herd immunity on the society. So this year, you'll find that there'll be a lot of work going on nationally through public health events to try and encourage people to take up flu vaccines as well as COVID boosters for those that are in that category. We did very well for our own staff group in society, and our own staff group, we were one of the highest in the country for uptake, we were way above 70%. We plan to do exactly the same. We already started our campaign in March this year. We're well on the way for that. We have a large constraints to that vaccine. We have plans to start it at the end. So Agility Week, we were through ACE. So we've been doing lessons learned with them. So Costa coffee vouchers will be available again if you take a vaccine.
What's having more luck this time. Thank you, Margaret. Any other further questions on winter planning from anyone that's looking online? Nothing online. Well, thank you, Laura. That's very, very helpful and very reassuring in terms of being able to hear that. It is one of those you don't quite know what you're planning for, but you just plan as best as you can. So it's good that we're here, and best of luck going forward. Right, that does allow me to then return now. Having to working for CCAM.
It's a sign. Nobody wants me to talk. I'll just carry on.
Thanks, Lulu. Do you want to add anything to that, Sarah?
Thanks, Steve-O. I think the only thing I wanted to add was just to alert the board to the fact that we've updated the board assurance framework to reflect the priorities in the HR improvement plan. So it's really just to turn people's attention to that and make sure we're now aligned for this year, 24-25, in terms of that board assurance framework, because otherwise it would have been out of kilter. That was it. Thank you.
No, thanks, Sarah, and that's a very helpful reminder to know that BAF is there for a purpose in terms of for us to have that assurance of performance, not just on each of these domains, but across the piece in terms of the delivery plan. Looking online, I don't see anything online. Is there anything further any colleagues have got? I mean, we have, as I say, we've spent a little bit of time looking at HR matters, but again, thank you for the work that's taking place within the committee, and we're hearing what you were saying in relation to both those areas that are working and the other ones that you feel require further attention. That then moves us on. We're on to Sustainable Partner, and I can move over to Howard.
Yeah, in summary, and I'll be as brief as I can, we are assured from a financial performance perspective, so it's really encouraging and pleasing to see that there are some shortfalls, but overall some mitigations. So from a financial performance point of view, we're in line to meet our 10.5 million deficit. As I say, that's very encouraging. Financial controls improvements, very assured about that. And as we heard earlier about operational performance, that is doing well. So you'll recall C2, we're at 26:37, so 26 minutes, 37 seconds. So comfortably within our 30-minute target. However, I will stand up for our C1 patients, where we're at about just over 8 minutes against a target of 7. And also Category 3 and Category 4, our performance has dropped off a bit on that. Interestingly, our position relative to the rest of the ambulance sector, we have dropped from top of the table to mid-table, so we're still doing well, but the reason for that seems to be that a number of others have improved their performance. Whilst we have improved it, they've improved it even more, so we've dropped down a little bit, but we're still mid-table, so it's a very good performance, and comfortably, as I say, within C2, within those sort of other C3, C4 reservations, also call answering, pretty good performance overall. The other point that's worth drawing out that we haven't touched on is the volumes of activity, which I think we just need to just a little bit more focus on. But the brutal truth is, we had a targeted, budgeted volume increase of 2.3% year on year. And the reality is very, very different from that. In particular, places like Sussex, we're 6.6% increase in volume year on year. Likewise in Kent, there's much less so in Surrey, interestingly, don't know why. A lot of that volume is coming from frailty and falls, in particular, and mental health is the other growth. But this sort of stuff doesn't really come out, and I think it's really important because it then determines where we shape our efforts through the hubs and so on. Finally, so that's all pretty positive. On the alerts, financial sustainability, obviously, despite doing well for this year, the truth is we looked at the 3-year plan, which is a sort of business as usual. So it's just saying, with no change, this is what happens, which is obviously not, we're not in a position where we have our 3-year sustainability plan, which gets us to break even. So lots of work going on. But as we stand here today, we do not have that. It is a part of our exit criteria to have such a thing. As I say, lots of work going on, but we don't have it at the moment. I think that's pretty much all I wanted to pick up on. Thank you.
Thanks, Howard. I'm just trying to think. Simon, do you want to come back in, add anything further? I know Simon does.
So I would observe that. I'd also say that the report of the committee that NHS England has now received from Treasury £2.2 billion national debt supply, which means that cash will follow to the source of that's a technicality, but if you're in certain hospitals through tech and statistics, you don't have sufficient cash this year to pay unless that capital force is forthcoming. Very important. So that's now been signed off quite a way through the financial year. It's not reported in the Note 5 position. We'll probably see that come through in the 6th, but what it means for us is we will be given, this was a subject of some fairly lively debate last night with chief finance officers. It means we will be given an additional £10.5 million in cash, which is helpful. But it also means we'll non-recurrently be able to work into this. But that's not really great. That's technical. It's non-recurrent. Just don't change anything in our fuel plan. It doesn't change anything in terms of our opportunities, financial control, improving our money. But we'll start to see stuff come through in the last 6. So quite a difficult position nationally. So it's really important for us that we deliver on the plan. We've committed to having met with the internal director yesterday. So this will come as no surprise that we are being asked to go further, which we have to take into consideration. It's not something that we haven't anticipated. It's not something that we just need to navigate ourselves through this process. And indeed, we can help to again in terms of our rounding our three-year plan, coming out of RSP, private group, council. So I think those are the only two additional items I want to bring to the board's attention. What is important and context pieces.
Thanks, Simon. And can I just apologise, colleagues online, because I think you're getting some of the audio, not all of the audio. Mark's having more gremlins than usual to deal with, so apologies if you've not been able to follow Simon's comments. But Simon, you've got further comments you wanted to add.
So I just wanted to pick up on a few and draw the threads of some of that discussion together, because it will be a key pinch point as we go into the months ahead. So firstly, on the precise point that you made, we reviewed operational performance yesterday, Howard. We picked up the challenge that you have rightly alluded to around category 1, 3 and 4. And in the context of the redraft or the continued drafting of the winter plan, I've asked that we look at how we can make sure that we are not just focusing on one area of performance. There is inevitably, when you create a target, a bias effect that starts to emerge, and we need to be mindful of that. The second point that you raised, which I think is really important and is a very live debate for those of you that are reading the HSJ nationally at the moment, you rightly pointed out that our activity is above plan. So it begs the question, if our activity were lower, would we be able to do more in the spaces that you've just described? We had a very helpful RSP meeting last month, in which for the first time I felt we genuinely had system-based conversations. In other words, the conversation was not based around CCAM, what can you do more of? It was systems leading a discussion about how they could reduce the demand that is coming to us. There is more in that space that needs to happen, and it will continue to be a focus this month. But I think we will, if the activity trend continues, approach a pinch point where there will be a fairly direct choice for us to make about we can't continue to maintain the level of performance that we have delivered within the cash envelope that we've got. And for those of you who are reading the HSJ, you will see that conversation writ large in one of our near neighbours in terms of LAS. So that, I think, is going to be quite a live debate for many ambulance services. On your point, and again this came out in the national press, about those services that have improved, some of them have improved, obviously, by the method of spending quite considerably large amounts of cash on delivering that improvement. And we see, and I would observe, an inconsistency in commissioning approaches where some are focused more on delivery of the cash, some are more focused on delivery of the performance, and we're treading this path, this tension constantly. So it's important that we are aware of that, because the winter plan, finishing on that, will go back to scrutiny. It will go to regional and national scrutiny, because obviously this is an area of quite intense political interest that we deliver on this over the winter period. And I think these debates will start to play out again. We don't have an easy answer to any of them. As Simon's just alluded to, on the other side of the dial, we're getting pressure now to go further. Well, if we went further, that would further constrain our ability to actually meet more demand. So it's a very complex and sometimes, frankly, contradictory set of impulses that we are managing here. Now, the place of resolution for us is this board. And so my final suggestion here is that it's not only quality and safety that take the updated winter plan in November, but I think all committees should look at it, because there's a people component, there's a quality component, and there's a money component. I'll leave it up to you to decide whether you do that all together or separately, but I think it would be helpful to look at it through those lenses to make sure that we are reconciling the tensions that those of us who have to live it on an operational basis are dealing with on a daily basis now. Thank you.
Yep, third time lucky. Very helpful, both Simons, in terms of your thoughts and additional perspective, because it's an interesting one. When we're looking with Stephen and digital, that's a particular landscape. Equally, HR is a particular landscape, but we have the wider sort of universe in which we're operating, and we're not free actors within it, and we need to understand and be cognizant of it. Simon says, yes, we'll certainly always be a helpful system partner where we can, but we also need to be able to sort of look at those sums of where we can do more activity against, we can, what the costs and the benefits of doing that are. So I think that's very helpful to have been able to set that out. We just have, if there are no other questions, sorry, looking online again, no other questions, then thank you, Howard, on that. We have two further issues. We have standing financial instructions of SFIs. I think, Simon, you're going to cover that one.
Excellent. So the board, one of the key financial controls the board has is the scheme of delegation, the scheme of standing financial instructions. Ours were 4 and 5 years out of date, so they have been now updated, approved by the executive and also reviewed by the audit committee. We shared these with external and internal auditors as well. They fall within the remit of the financial controls enhancements the executive committee also approved. But it is entirely the board's responsibility, and only the board's responsibility, to approve them. So they are here today for final approval, and that's audit committee's recommendation as well as mine.
Thanks, Simon. Did you want to add anything onto that, Michael? Yeah, I think it might feel like a technical one, but I'd also say, since coming in, just seeing some of your focus, some of your energy, Simon, of just basically getting some of these simple things, or might see simple things, and you could stand away from them and dealing with our commissioners and other such things, but you've also gone into these details and basically getting us better, more fit for purpose. So I think that just to say on behalf of the board, thank you for the work on it, because I think it's these types of things, they deliver longer term dividends if you put the energy and effort into getting them right. So I think we need to do an approval. So there we go. I've got an approval for those. So thank you very much. And then in a similar light, procurement strategy.
So the procurement strategy, again approved by Executive Committee, been reviewed by Finance Committee and recommended for approval by Finance Committee. This is a refresh of something. It is written to support our overarching strategy. It takes particular steer from the standing financial instructions now being updated and in line with current public contract regulations. Significant amongst them, we are now much less prepared to accept non-procurement as the standard approach to spending public money. So we will be complying with SFIs and this procurement strategy going forwards, which means it's just getting better value for money and spending our money well, which is what we should be about. Yeah, very happy to recommend this. Really happy to do that on behalf of Jeff, who's done a lot of the work to bring us up to a better standing in procurement terms. So here for approval as one of our key enabling strategies.
Thank you for that. Look, I'll just ask that question of how might that then relate to the southern area work being done. I mean, I presume it's preparatory, but
so Jeff's a part of the procurement group, the working group that sits within that collaboration. This was more about how do we get our house in order. So how are we assured that we have financial control within the remit of the Foundation Trust and our public responsibilities? But there's nothing in here that we wouldn't expect to see across the collaborative. And indeed, having, as part of this strategy, been clearer about our procurement pipeline, what we are going to procure, when we're going to procure it, makes us much more likely to be compliant with the new procurement regulations when they come in February, but also it's a key piece of information that the collaborative would want to be. So we'd expect the 5 teams to be sharing their procurement pipelines, seeing where they have areas of commonality, agreeing what we can go together on, or where we need to do that separately.
very helpful. I mean, that's going to certainly mean that we can get, you know, further benefit, especially if we are able to work at scale as we are planning to do. Anything further? Everyone's hungry, aren't they? I can see they're all hungry. But first, you have to do the board effectiveness to be able to say. And any thoughts or reflections? It'd be interesting to get the thoughts and reflections. I might also, not sure, Steve, whether you're allowed to make a contribution, but I'd be very interested to hear a contribution in terms of board effectiveness. I mean, particularly in terms of how we're scrutinising over our three domains. I mean, certainly for chairs, thank you so much. I think you're very much working exactly to the agenda we were talking about in terms of assurance. I wonder what else we might be able to add on scrutiny, but maybe, Steve, would you have any?
I wish I had some prep too.
I certainly felt that. I could see those values coming through across everything we're doing, what we're doing, and also how we're doing it. So, well, if that's us, then I can just say we've Peter gave us the extra half an hour because he thought this might require the full half an hour, but we've actually brought it in just a few minutes over its original timeline of 1 o'clock. So if there is any other business, and if there's not, and do we have a date and time of the next meeting?
December, whatever the first Thursday in December is, forget the out of my head. Let's call it the 4th.
We'll call it, just start hanging around at the beginning of December, and you'll probably knock into a board meeting at some time.
5th of December.
5th. There's also a moment now for any questions from, as I say, I don't know if we have colleagues online or...
So yeah, just say so we ask for questions in advance now.
All right. So yes, we haven't. So we don't.
No questions were received.
There are no questions received. All right. Thank you. Well, thank you all. Thank you for being in attendance. It's always fantastic to be able to see staff members and members of the public taking advantage of that. So thank you for that. Thank you everyone for their contributions. And yes, we can go and get a bite to eat.